Welcome to the podcast. My name is Dr. Noor Gajraj. Let's talk about a very important subject, suicide prevention, a public health imperative. The urgency of prevention, global and US prevalence. Suicide is a leading cause of death worldwide and in the United States. In 2023, nearly 50,000 people died by suicide in the United States, which equates to one death every 11 minutes. There were an estimated 1.5 million suicide attempts. Globally, according to the World Health Organization, more than 700,000 people died by suicide in 2019. Beyond completed suicides, over 12 million US adults reported experiencing suicidal ideation in 2021. These aren't just numbers, they represent immense suffering and loss, emphasizing the scale of this public health crisis. Demographics and disparities. Who is at risk? Suicide is the 11th leading cause of death in the United States. Age. Suicide is the second leading cause of death for individuals aged 10 to 14 and 25 to 34 years old, and is the third leading cause of death for those aged 15 to 24 years old. Children as young as 5 years old can experience suicidal ideation, and completed suicides, though rare, occur in elementary aged children. Gender. Men die by suicide at a rate approximately 4 times higher than women. Racial ethnic groups. Specific groups such as American Indian, Alaska Native individuals often have significantly higher suicide rates compared to other racial ethnic groups. Understanding these patterns is crucial for targeted prevention efforts. Understanding risk factors beyond mental health. Suicide is rarely attributable to a single cause, but rather a complex interplay of risk factors. While mood disorders contribute to 60% of all suicides, it's important to note that the majority of patients with psychiatric disorders do not attempt suicide, and about 10 to 37% of individuals who die by suicide do not have an identified mental health condition. Understanding risk factors beyond mental health. Other critical factors include psychosocial problems, job loss, relationship breakups, inability to develop close relationships, neurobiological mechanisms, central nervous system, serotonergic and hypothalamic pituitary adrenal axis dysregulation, genetic risks, a family history of suicide, medical diagnoses, specific neurological conditions like epilepsy, Huntington's disease, head injury, and strokes, prior suicide attempts, a significant predictor of future risk. Screening and assessment, identifying risk. Healthcare providers, including those who care for adults and young with epilepsy, are uniquely positioned to identify individuals at risk for suicide. Talking about suicide or asking someone if they feel suicidal does not increase the chance of a person will act on it. It is always important to take seriously anybody who talks about feeling suicidal. Developing and implementing a suicide screening policy in clinics is vital. Two readily available validated options are available. The Ask Suicide questions. 4 brief questions. Takes about 20 seconds. High sensitivity, validated for ruling out risk, available in multiple languages. Has youth 8 to 24 and adult 18 years plus versions. The Columbia Suicide Severity Rating Scale. 6 questions, approximately 5 minutes to complete, identifies risk severity, gauges support needs, cross-culturally validated, includes a version for very young children, 4 to 5 years old. Who and when to screen? All patients with specified frequency, e.g. during clinic visits. The plan for a positive screen. protocols for active risk, high-level care like inpatient hospitalization versus no acute risk. The Ask Suicide screening questions. A single yes immediately flags the individual for further, more comprehensive assessment by a mental health professional. The four questions, the adult versions. In the past few weeks, have you wished you were dead? Number two, in the past few weeks, have you felt that you or your family would be better off if you were dead? In the past week, have you been having thoughts about killing yourself? Number four, have you ever tried to kill yourself? For youth aged 8 to 17 years, there's an additional fifth question. Are you having thoughts of killing yourself right now? Evidence-based intervention, safety planning. For patients with positive screens, further assessment and appropriate interventions are crucial. The self-T assessment is a useful tool to determine next steps, identifying risk protective factors, conducting suicide inquiry, and determining the risk level. Regardless of whether hospitalization is needed, safety planning is a brief evidence-based intervention that significantly reduces the risk of self-harm. A safety plan intervention involves identifying triggers or warning signs, identifying internal self-coping techniques, strategies for distraction and external support, personal contacts who can be supportive during a crisis, professional agencies, the suicide and crisis lifeline. Lethal means restriction, reducing access to potential means. For example, recommending gun locks, safety, medication storage. This is paramount, especially for youth. In conclusion, suicide is a complex and devastating public health issue, but it's preventable. Understanding its prevalence, the diverse demographics affected, and the multifaceted risk factors, including specific vulnerabilities like epilepsy, is the first step. Recognizing the warning signs and utilizing evidence-based screening tools are crucial for identification. And finally, implementing robust safety planning and connecting individuals to vital resources like the 988 Suicide and Crisis Lifeline empowers us all to make a difference. Let's work together to reduce stigma, promote mental health awareness, and ensure that hope and help are always within reach. Thank you for listening to this talk. Please consider buying my book, 100 Pathways to Longevity, and subscribing to this channel.